Good afternoon, everybody, and welcome to Grand Rounds. Today, it is my pleasure to introduce Dr. Peter Georgakakos. Dr. Georgakakos is a board-certified emergency physician. He is a clinical associate professor at the University of Iowa. He's also the director of the Division of EMS at the University of Iowa. He's the program director of the EMS Fellowship at the University of Iowa. He is the medical director for the Johnson County EMS Services. And he also is medical director for the Bureau of Emergency Medical and Trauma Services for Iowa Department of Health and Human Services. And so the CME committee is very appreciative of his taking time out of his obviously very busy schedule to join us today and give us a critical appraisal of cardiac arrest care. Please join me in welcoming Dr. Georgakakos.
Well, thanks for having me. So just a little about me so you know who you're listening to. So I was born in Iowa, but I grew up in San Diego. We moved, as one does, from Iowa to San Diego. And so I graduated high school there and wanted to go as far as possible. So I ended up in Boston. And so I went to college in Boston. I had become an EMT at the end of high school, fell in love with it. So worked a few pre-hospital and in-hospital jobs in EMS while I was in college. And then I did the paramedic program at the University of Iowa. Worked as a paramedic for a while, and then basically on a dare applied to medical school before my MCAT expired, and got in, went to Kirksville, and then did residency and fellowship at the university, and then stuck around. So in my first role at the university, besides with Johnson County, I was the medical director of the EMS LRC. So I've had a lot of graduates come and work here. So I'm excited to be here because I've only ever known this as a site where you all take our students. So thank you. But I'm excited to talk about this. So this lecture has evolved over the years. So it really started, basically bred out of my intense frustration with ACLS. Thankfully, ACLS has been catching up to the literature, so the spirit of this lecture has changed. It used to basically be dissecting ACLS and why it wasn't evidence-based, and there were so many better things we could be doing. But now, as they've started to kind of catch up with us, I think there's just some important things within ACLS care that we do. We all learn, we all every 2 years, recertify, but it's just talking about, my goal is to just have you understand where the emphasis should be logistically, because these are things we do all the time. We all get good at just repeating, what they need to hear for the AHA to give you your card. But I think it's important that you understand where some of these interventions come from. And as you are, whether you're in the austere environment in the field, whether you're in a hospital, whatever the circumstances may be, you know what you should be prioritizing. And so I updated this most recently, so it should have the most updated ACLS guidelines. So we'll go through those guidelines, not exhaustively, just hit a few of the high points. And then we're going to go through the specific interventions that ACLS talks about from a literature perspective. I am by no means an academic, so my literature review is very surface level, but I think there's some common themes that it's important to know. We'll talk about the pit crew model. Thankfully, that's no longer a novel idea, so I don't think I need to describe it in too much detail, but just talk about some proposed ways to think about doing it, depending on how many people you have and such. And then we'll talk about the relative importance of the basic interventions versus the advanced. So in the United States, as of 2019, there's about 356,000 pre-hospital arrests, about 209,000 in-hospital arrests. In general, we're just going to be talking about adults and just medical arrests. Traumatic arrests are a totally different thing. Pediatrics is a different thing. But in the adult medical world, most commonly, there is a VFib or VTAC arrest. Now, that often degrades into a non-shockable rhythm the longer they're in that no-flow state. So it's really just a matter of how fast does someone get to them? How fast does somebody get to them on the monitor? But within 3 minutes of an arrest, up to 70% of those patients can get ROSC. So we talk about the no-flow state when someone collapses and there's no compressions done, and the low-flow state, which is we're doing our compressions, but they're still not as efficient as a heartbeat. So we're trying to minimize that no flow state, but within 3 minutes, hands on the chest, up to 70% ROSC. That said, every minute after that has a 10% decrease in survival. And so this is where some of those public education things came out of. So public access defibrillation, teaching bystanders CPR, all those things, is we are just trying to minimize that no-flow state. And we've seen marked success. So again, the longer there's no flow, the less likely they'll stay in VFib. Obviously, in hospital, we would hope that those in cardiac arrest are recognized faster. So we are getting hands on the chest faster than in the field. But overall, the kind of standard survival is 5 to 15% with a good neurologic outcome of 8.4%. So back in the day when I was in EMT school, paramedic school, really the outcome we were looking for was ROSC. Over the course of the years, we have found through studies, through discussions, through public surveys, that's not what we all consider meaningful survival. Just because you have a heartbeat does not mean you have survived. And so really the paradigm has shifted to survival being you have a heartbeat and a good neurologic outcome. So really, as I'm talking about survival, that kind of thing, that's often the metric we're using, because we used to all high five that we gotten a heartbeat back. But if they have no brain function, that's really not a victory. So the standard in the country is usually between 7 and 8% of survival with good neurologic outcome. So interestingly, there was this study done that showed an out-of-hospital cardiac arrest of healthy adults under 40. They did this huge retrospective analysis in the US to just see what is happening with what should be very healthy people. And so they found that there was a cardiac arrest in a healthy person between 4 and 14 per 100,000 person years, with about 10% survival. 60% of them died out of the hospital, so they were never fully resuscitated because they were clearly dead. So sudden cardiac death, arrhythmias, structural diseases. But then 40% were brought to the hospital and survived a hospitalization. 9 to 16% would survive to discharge. But those that survived to discharge in the young, healthy patients, 90% of them had a good neurologic outcome. So there is some demographic factors that clearly affect things, age, comorbidities, all that. But overall, universally, even before this study, but this study agrees, one of the main influencers of outcome is the quality of CPR. And we've known that for a while. And so the last few iterations of ACLS and various education modalities have talked about how do we optimize CPR. So let's go through ACLS a little bit. So these are probably the main changes for those of you that know ACLS very well. I'm not going to go through them all, but these are the main things as they did this update in 2025 that have changed. The main one is there's now this universal chain of survival. There's not 16 different ones depending on your various scenario. There's just a main 6-link chain of survival. There's more of a focus on how we effectively treat choking. Infant CPR guidelines have changes. And then the opiate overdose, unfortunately, because it's become such a big deal, is becoming one of the main priorities. We're teaching laymen, we're teaching law enforcement, we're teaching everyone, and making naloxone heavily available to everyone. So that's been a big priority, even for the bystander layperson BLS. We've reprioritized, it kind of goes back and forth, and we'll talk about this a little bit. Reprioritized IV as the main source of access. I'm going to give you some literature to chew on to decide if you think that that makes the most sense, especially in the austere environment or with limited staffing. Temperature control, more in the setting of return of spontaneous circulation. There's some new special guidelines regarding neonatal, drowning, hyperthermia, and then just overall some concepts about how we are doing feedback and training. But ACLS, thankfully, is repeatedly progressing. So this is that singular chain of survival for adults and pediatrics. You have the recognition piece, which is always what these public service ads are trying to do, get people to recognize so that they know to call 911, all with the priority of decreasing that no-flow state. Furthermore, to decrease that no-flow state, we're trying to teach people how to get hands on the chest. Defibrillation, then we get to the advanced resuscitation. This is now when the professional providers have arrived. We're optimizing post-cardiac arrest care, and then there's become a newer focus on the recovery part. we save these people, but there is a huge long road and emotional toll they have of them, their families, all of that. And so now that's more of a focus as well. So this is the algorithm everybody knows and loves. It really hasn't changed a lot. Really what changes is if lidocaine or not is involved. That's what keeps coming in and out and gets pulled out periodically. But more importantly, on this far side, there are finally some things that are available on the card that I think are super important. So there is a whole section in that top part. I tried to make them bigger so you could see it. The high quality CPR emphasis. It actually tells you the components of high quality CPR instead of just telling you to do it. With regard to the defibrillators, there are still those monophasic defibrillators that you keep increasing the energy. Biphasic is preferable, and every manufacturer has a different default, as you know, and it's that big number that's on there, 120, 150. But the literature has shown that you can go straight to the highest one. There is no injury to the heart muscle if you start at 200. We finally removed vasopressin. That's another medicine that periodically will pop in and out of the algorithms. And now there's a heavier emphasis on continuous capnography. So what are the components of high quality CPR? Well, again, these are things that those of us that do it a lot, it's a no-brainer. But it's, again, if you are in the position of authority, educator, or team leader, now you know what you're looking for. So we want to maximize the chest compression fraction. So in the period of time of a resuscitation, that CCF is how much time or hands on the chest. And that has to be as much as possible. We want to have a good rate and a good depth. And between each compression down, we need full chest recoil to allow blood to fully fill the vessels. You want to avoid excessive ventilation, change compressors every 2 minutes. This is something that, especially if you are coming upon lay people, it's really important to do, because the moments of adrenaline, these very well-meaning lay people won't realize that they're going to get real tired. 2 minutes doesn't sound like a lot, but the worst thing that can happen is 2 minutes, 30 seconds in, they just say, I can't do it anymore. And then in the middle of a new cycle, you have to stop and change. And then continuous capnography. So why do we care about compressions? So if you think about what compressions are doing, it's trying to move, it's doing two things. To a very small degree, about 30% efficiency, it is pushing blood through the body to make sure the brain gets blood, the rest of the body. But more importantly, it's going to the coronary arteries to keep the heart perfused. So again, compressions are not a treatment, right? They are a bridge to get them to the treatment. So if you look at this picture, this is somebody getting compressions, and this is the coronary perfusion pressure. So look at how much time it takes to get the coronary perfusion pressure actually going up to a meaningful amount to keep the heart perfused. Well, every time we stop, that number precipitously drops. And that's why there's such a focus on less than 10-second breaks. So in the codes I'm a part of, I'm really obnoxious, and I count down from 10 because people in the thick of it, including me, do not realize how fast 10 seconds is. So there are times that it could be 17, 19, 30 seconds, and you think you're still in that 10-second phase. And this is why that matters, because you lose all that hard work you just did for 2 minutes. You can lose it in seconds. So we're trying to maximize the amount of time compressions are done because we're trying to improve coronary blood flow. So when we've looked at studies, we know this is important. This is all in professional providers. We are still not good at depth, and we still have hands off the chest far too long. So how have we tried to improve this? Well, we've tried to improve this with post-incident review. We've also tried to do this with real-time feedback, whether it's from a team leader. AHA is big on the CPR coaches, but also the actual defibrillators themselves can have feedback, which can be very helpful. So the other big thing they started focusing on during the last update was the team dynamics, which is great. You need people, and those people need to have roles. Ideally, it depends on the system, depends on if you're in and out of the hospital, but ideally, people are arriving on to the resuscitation already knowing their role. So, often our fire crews will come in and they know captain's chair is one person, driver is this role, Person in the back seat is this role. Same with the ambulance, that kind of thing. So the point is, though, that you know all the roles, you've practiced, and you do think through positioning. Sometimes we do this without thinking in the ER, just based on where the defibrillator is. It's clear where that person will be. The head of the bed, obviously, is the airway. The compressors are over here. But that's not always true when you're sitting in a kitchen. And so it's important to talk through some of those things. And there's two sections of roles. There's the leadership roles. So the team leader, the timer and recorder, which I would argue besides compressor is the most important person because they run the code. They keep you honest on times. They tell you when there's pulse checks. They are your brain. And then the person with access and meds. Then you have the resuscitation triangle, the people actually keeping the patient alive or trying to get them alive. You have the compressor, the monitor, and the airway. So this is just a sample. This is out of a protocol in a North Carolina EMS system. They have gotten it so focused down that they actually tell the providers during a code, this is where you will stand. This is where you will more likely bend down. But it tells you exactly where you go. It also tells you after where you're going to transition to. So again, by no means do you have to have a map like this, but just this agency understands the importance of this and wants their providers arriving on scene already knowing where they should be going. So team leader is obviously running things, assigning roles, treatment decisions, feedback. They are the CPR coach, which I think is really important. When you've done this long enough, you can sense when compressions are too slow, too fast. You can look and see that they're too shallow. So you just want to keep people honest. And then access and medicines, obviously, and then the timer recorder. Ultimately, the compressor and AED person or defibrillator person can be switching roles because presumptively the airway person is establishing an airway and then bagging until you have them on a ventilator or whatever. But generally speaking, assuming you don't have a ventilator and RT, you just have somebody that's going to be bagging, the compressor and defibrillator are the two most mobile people that can switch places. So that's ACLS as we know it. That is the cardiac arrest care that we always do. So what's some of the evidence behind it? Well, like we talked about, we know that compressions are how we bring up that perfusion pressure, but the only way they effectively do that is if they're continuous and uninterrupted. Hands-off time, the more hands-off time, the less they survive. This is why we care so much about CCF, and this chart exhibits why that's true. So again, the more real-time feedback you can get, the better. However, the importance of understanding that as we have pushed more and more to continuous uninterrupted compressions is the paradigm shifted in the pre-hospital setting. So this suggested, so we have evidence that tells us we are not good at compressions when we're on the move. We've also shown that every interruption is bad. Well, to get a patient between the toilet and the wall out of that room into the ambulance after getting them on a cot and then on the move, likely going to be a lot more than 10-second breaks. So you already have that transition that's not great. We also have these very creative studies out of Japan that put these poor people through these simulations in the back of an ambulance of different turbulence, trying to do manual compressions, from simple going down the road to what looks like, you know, they're on the Titanic. I don't know, but it is, we do not do compressions well on the move. So you have these two things that are both paramount to pre-hospital care and transport affecting the most important part of survival. So the paradigm shifted. We need to stay on scene. We need to minimize interruptions. We need to maximize our compressions. Because again, my compressions in the hospital are no better or different than in the field. I would argue the amount of turnover we have at the patient care tech role, the guys in the field are doing it way more. They've done way more CPR than most of our staff. So again, there's nothing magically different between in and out of hospital, with some exceptions, and there are definitive exceptions that should be transported. So your gravid patient, hypothermia, pediatrics, you know, those aside, just your run-of-the-mill, middle-aged, older person with a medical arrest, stay on scene. There's not really a set scene time. Literature varies. You know, some of the air literature suggests 20 minutes, ground 30. So somewhere in there, you can say you have done an effective resuscitation in 20 to 30 minutes. So there's something called the Verbeek-Morrison rules that are termination criteria. And the point of that is not to have more dead people. It's to minimize futile transports. And that takes into account some of the time on scene as well. So this is what fits into that. So somewhere between 20 and 30 minutes, you stay on scene before you're saying this is futile. Well, if we want uninterrupted compressions, then we talk about the Lucas device. That came to solve all the problems. If humans are not good at CPR, let's have a machine do it. So you have all these various iterations of mechanical CPR. So it was, in theory, it's supposed to give a consistent rate and depth. Doesn't matter if you're moving, anything. The only thing the manufacturer asks is that the patient stays parallel to the floor and you don't tilt it. That said, it's limited by battery life. It only fits certain body habitus. You can be too big and too small. The extrication movements, if you're ever going downstairs, you have to stop it because now you're angled. If there's any risk of it tilting, I've seen them flip. You have to be very careful when you move. So does it improve outcomes? In theory, it should, right? If we're not good, if we have bad depth, this is consistent depth and rate, should it be better? So Newberry does a study that showed worse neurologic outcomes with the Lucas patients. But then when you remove the confounders, there was no difference. This was not the difference maker. Sheridan did one that said no change in ROSC, but it could be more beneficial in the non-ideal situations. And those non-ideal situations are when there's no bystander CPR, when it's unwitnessed, when there's a delayed EMS response, but then also just more generally in the austere environment. It makes sense. When you have two people, you don't want to waste one on compressions when you have a machine that can do it. So again, it's important to understand it is not necessarily the problem, but it is not the difference maker. The other big thing that unfortunately has been shown pretty regularly is that if you are not using the neck strap, it migrates. And there have been multiple cases. We're looking at this at the medical examiner level. There have been multiple cases of pretty severe liver lacerations, splenic lacerations that have led to a patient's death because they bleed out, because we're busy with the medical arrest. No one's doing a fast exam to not understand why are they full of fluid. So it's very important to understand the limitations and that this is not the difference maker. The other thing anecdotally is the amount of time spent on the mechanics of getting it on, reattaching it, unattaching, all this stuff takes way longer than 10 seconds to transition them. So again, may be useful, but shouldn't be relied on. So now one of the newer things, so I give this lecture to our fellow every year, and every year I try and pick one of the new hot topics. And a couple years ago, it was heads-up CPR. And so the most common cause of death within a cardiac arrest is the anoxic brain injury. So the thought was, well, how do we minimize that? And so one of the ideas was changing the patient's position. The reason for that being when their head is up, you now have blood draining out of the brain. It's not pooling, but because now they're also a little bit flexed, that brings increased preload back to the heart. And so both the brain draining, the blood draining down, and since they're flexed, blood coming up a little bit should increase venous return, which increases coronary perfusion pressure, mean aortic pressure. So these are all things in theory that this should do. So there have been a bunch of studies. So Varney did this big meta-analysis of 18 studies that showed a significant increase in cerebral blood flow during compressions, because you're still doing your normal resuscitation. They just happen to be sitting upright a little bit. It increased your coronary perfusion pressure, your cerebral perfusion pressure, but there was no difference in survival outcomes. That said, none of these 18 studies were human models. All of those were done in pig models. So then Kim et al. Did this really interesting study with infrared spectroscopy. So they strapped these two patients' foreheads while they did CPR to see the blood flow through this spectroscopy. And so they alternated patients every 4 minutes, I believe, between heads up and supine to see what was blood flow like through their brain. And they found in the head up position in 83% of patients increased cerebral blood flow. So it does work in theory. So Pepe is kind of the big one. Their group produced 3 studies kind of confirming their own data to say this is why this is such the difference maker. So they did a before and after study, and they had 2 treatment bundles. one of them involving heads-up CPR. They found all outcomes had improved, but they really didn't delineate what those outcomes were. They just said all survival outcomes were better. But overall, when you look at just survival with favorable neurologic outcome, there was no difference. Then they did a study in 2022 where they matched cohorts, so similar demographics, similar patient populations. They matched them. So they used the data from their previous study and then matched them with 350 heads-up patients. And that said, these were only non-shockable rhythms. They weren't looking at shockable rhythms. And they found that the heads-up group had higher survival, 4% instead of 1%, which is still not even the survival we've talked about, right? We said it's 8 to 15%. So then in 2024, they did another one where, they're still using all their same patients from their other studies. And they found that the heads-up group had higher survival with good neurologic outcome, 5.9% versus 4%. So in their minds, they have proven this is a huge victory for this intervention. This is the difference maker. Bondarenko agrees, cited all the studies we've talked about and said together, this seems convincing and should continue. Another systematic review kind of said, yeah, it did all say that, but these studies were very low quality. None of them actually studied the out-of-hospital cardiac arrest scenario, and only 2 of them had human models. So ultimately, the answer in heads-up CPR is there's no obvious harm, but further research is required. Both the European and the Western resuscitation councils have not adopted it, but everyone just agrees we need to at least be on the lookout for it. So this is right out of the European Resuscitation Council's annual document. Despite an apparent improvement in favorable neurologic outcome, there's insufficient evidence to indicate the routine use of heads-up CPR. Basically, without telling us what else of that treatment bundle, without knowing what was helpful, it's hard to say the heads-up part has to become universally adopted. They suggest against its routine use in isolation. So that's compressions. Defibrillation. This is the most effective intervention with VFib, VTAC. So we've talked about this already. We found biphasic was a huge success and a huge groundbreaking benefit. There's varying energy levels. Sometimes AEDs can be converted. Understand, though, that AEDs are very not ideal when you're a professional provider, because if you think about the AEDs, when they're analyzing, your hands have to be off them. And that delay can be up to 49 to 59 seconds, which is not great. If it's a layperson and it's either do nothing or let the AED work, of course, that's better. But when we are there, that delay is catastrophic. So then there was this question of, well, what if you come upon someone, it was unwitnessed, but they're in VFib? Some people said, well, it's VFib, shock it immediately. The concern was that if they've been down for some period of time, they've been accumulating damaged cells that have free radicals and various things that might not make the heart shockable. Basically, it's not going to be as receptive to the shock. So you have those that say just shock immediately. You have those that say let's optimize the heart by doing compressions first. So a study, there was a big randomized controlled trial that did compressions versus initial defibrillation. There was no difference. Smaller studies suggested CPR first. If it's been at least 4 minutes, had better outcomes. So ACLS says if they're witnessed, obviously they're more freshly dead, so their heart is more ready for the shock. If it's unwitnessed, you should do a cycle of CPR first. So I'm going to fly through this one because this is its own multiple lectures that there is not an answer. That's the punchline. So there's some concerns with the airway. So it was always intubate in paramedic school. That's why I became a paramedic, was to do IVs and intubate. Well, the big concerns are the tube can dislodge. You might try a bunch of times. You have a bunch of failed attempts. Every failed attempt makes your next one more likely to fail. You might be hyperventilating, which can affect intrathoracic pressure, decrease venous return. But the main concern has always been you're doing tasks that take you away from the main thing, which is compressions. So there's a lot of studies done to say, so what should we be doing? So every year at our national EMS assembly, this is one of the things that is always talked about. The supraglottic airway guy and the intubation guy just fight. And they always talk about their newest study and why they're still right compared to last year. So Ultimately, it's important to understand that BVM ventilation is physiologically adequate. There's actually really interesting data that pediatric BVMs might be better for adults because we grossly overinflate people. But ultimately, understand that. The whole point here is just to ventilate them. Capnography has become a very useful tool. So early in a resuscitation, if you have low capnography, your compressions are not good. Later in a resuscitation, if you have poor capnography, their prognosis is not good. That said, though, no matter what, even in a low flow state, you should be able to use capnography to assess your ventilation if you've placed an endotracheal tube. Keep in mind, though, I've seen this a few times, that even if the endotracheal tube goes in the esophagus, there's CO2 in the esophagus. So your first squeeze or two, you might see a bump in the capnography. So traditionally, they say we want to see 8 good waveforms to know effectively, okay, this isn't just cleared CO2 out of the esophagus, I am ventilating a trachea. Ultimately, there's some studies that say, well, maybe advanced airway is actually improving outcomes, so we don't have a good answer. The ultimate answer is it's based on your system, your providers, the number of reps they're doing. So in my system at Johnson County, we do not do RSI in the field. That is not because I have any doubt in their abilities. It's because it's not a competency concern, it's a reps concern. So the average ER doctor will do 10 or 11 intubations a year to be deemed competent. And I do not have all of my 110 paramedics doing 10 or 11 intubations a year. Yet, if I allow them to, that time it's indicated, they are going to be held to that standard, assuming that they've done 10 or 11 in a year and can do it effectively. There's nothing in the literature that suggests intubation grossly maximizes a patient's survival. So you have the PART trial, the Airway 2 trial. Those are the two major trials that suggest supraglottic airways are better. They have the King LT. So when I was in paramedic school, that was this newfangled thing that was going to right all the wrongs of the combi tube. So the King LT had better 72-hour survival, ROSC, neurologic survival, and it was much faster. You put it in 2.6 minutes, faster than endotracheal tubes. And in that study, only 50% of the tubes went in the right place the first time. The Airway 2 trial showed no significant difference in survival to discharge with good neurologic outcome. But when you took, that was just a binary intubated or not. So in the intubated or not, there was no difference. But within the not intubated group, when you took out those that were only ventilated, so with a BVM, so now you just had supraglottic airway patients, they did have better outcomes. Then you have Harborview in Seattle. They are the model of an EMS system that does intubate in the field, but they have a very specific system. They have an intensive care paramedic per 10,000 residents of a system. So they have like 14 or 15 of these paramedics. That's all they do. They just drive around and intubate people. Their call volume is such that they maintain that. Their median attempts a year is 11. So they are far and away probably intubating more than most of my partners at the university. So again, they're better at it because they do it all the time. So they have good no pause in survival, good first pass success, and overall 93% of their patients are intubated. So this medical director comes every year and says, see, this should work, but we're not all built that way. The National Association of EMS Physicians says it's completely based on the skill of the clinician, available resources, but any of these can be considered. Airway management should not interfere with other key interventions. That is the key here. Yes, they need an airway, but that should not be the focus. As fun as it is, as paramedic-y as it is to feel like you're doing that, as you know, it feels fun to do things. Our residents want to intubate anything that moves, and it's a fun skill, but it is just not the priority. Capnography should be, though, no matter what you're doing. It guides ventilation, compressions. Often, if there is poor perfusion, pulse oximetry is worthless, and it's usually behind. Capnography is a better mechanism. So to that end, within ventilation, so they are now recommending that instead of anything else, the way that you know you're ventilating adequately is chest rise. That's it. So a third or half of a squeeze of the BVM, and then at a rate of 8 to 10. We are trying to minimize hyperventilation and too much positive pressure, because if you're squeezing too hard, That esophageal sphincter opens and you're just dumping air into the stomach. Bystander ventilation. So since COVID, there's been a huge hesitation in bystanders coming up to strangers and just doing mouth to mouth. So telephone CPR, which is being taught to dispatchers, is compression only. And they actually have pretty compelling data that they have impressive survival. So again, they get earlier and more compressions, even if they're not getting ventilations. So while it doesn't increase survival, it doesn't worsen it. So again, if people are unwilling to do ventilations, that's okay. As long as they have good compressions being done, that's okay. These impedance threshold devices, this is another thing that in theory is great and should be utilized constantly, but they're expensive and no one uses them. So it's a one-way valve attached to the endotracheal tube or your BVM. It increases the negative intrathoracic pressure during recoil. And so it's basically just so that the effect of your compressions allows airflow to still be normal without the pressure changes of your compressions messing with things. It increases preload and coronary perfusion pressure, but you really just don't see them in real life because, of course, like everything, they expire and no one wants to pay for them because they don't make tons of sense practically. So medications. The medications of ACLS are from tradition, theory, and animal research. None of them have demonstrated improved outcomes. Thankfully, recently, in the last couple of years, ACLS has started to downplay the medications in favor of high-quality CPR. This most recent year, they removed vasopressin, and then lidocaine, like we say, it just depends on the day if it's involved or not. So epinephrine. Epinephrine is kind of the foundational pressor that we're using. But you have to understand the trade-off, coronary versus cerebral perfusion. Vasopressin, which isn't relevant anymore, just works on vessels. The animal data showed, and this is why epinephrine was ever involved, it showed increased ROSC with early epinephrine or vasopressin. They did a vasopressin plus epi versus epi alone, and there was no benefit in adding vasopressin, which is why they've gotten rid of it. But other trials show that they got more ROSC. You will see that repeatedly through these studies. Epinephrine will get you more ROSC. But again, enough epinephrine will give a rock a heartbeat. That's not our question. Our goal is not a heartbeat. Our goal is meaningful survival. So there's no improved survival to discharge. So then there was this question of, well, if some epi is good, is more better? So when I was an early paramedic, we were given 5 to 7. I had partners that were given like 11 milligrams of epi, just thinking, well, let's just keep giving more. We're getting a heartbeat. Let's see what else we can do. No increased survival. So Jacobs in 2011 finally did a randomized double-blind epi versus placebo. And they found, again, epi had more ROSC, about 3 times more ROSC, but there was no difference in survival to discharge. In 2016, we had another one. These were all now in the non-shockable. PEA had better survival compared to asystole, which we get, but not neurologic intact survival. So again, does epinephrine help? It depends what you're looking for. So ROSC or survival to discharge or with good neurologic outcome. And this is where the Paramedic 2 trial came in. This came out a few years ago. This was a massive trial, both in its size and importance. So it was a randomized double-blind trial in the UK. So they gave 4,100 patients epi and about 4,000 patients saline during a code. They found that survival at 30 days, epi group was higher. Survival to discharge with good neurologic outcome, there was no difference. And severe neurologic impairment, epi group was higher. Because again, we're getting heartbeats and we're keeping people alive with no brain function. So ultimately, repeatedly, in all the metrics they looked at, epi had more ROSC, not more survival, and even trended toward potential neurologic harm. So ultimately, what Paramedic True does not say is that epi should be taken out. That study hasn't been done yet. But there is a lot of data to sift through. So through animal models, again, you're seeing certain metrics that improve. In a Norway trial, you saw short-term survival improve, long-term go down. Japan, you saw decreased survival. But ultimately, there was this big meta-analysis that said epi does not improve survival to discharge with good neurologic outcome. So again, we can't say that it should be removed. I really hope by the time I retire that C-collars and epi are removed, but we're not there yet. So should we change frequency? There was a study done, because ACLS is every 3 to 5 minutes. So basically every other pulse check, you do an epi. So they did this interesting study of different intervals, so less than 3 minutes, 3 to 5 minutes, greater than 5 minutes, to see if the outcome was affected by those intervals. But they had to get at least 2 doses of epi to actually be included in the study. And it was a massive study. The median dose interval was 4 minutes, which is what ACLS would suggest, right? Every other pulse check. Survival to discharge was about 4% with good neurologic outcome. And they found that longer dosing intervals was associated with lower discharge with good neurologic outcome. So what this author walked away with said, shorter intervals are better. Shorter intervals, more survival. But there was a ton of bias within this that didn't really elicit much demographics about the patients. It didn't tell you a lot about the EMS service, their breakdown, their providers and deployment. So it's hard to know. So this was probably the most recent studies that came out on the next slide, talking about route. So like we talked about, they have reprioritized IV as the main route that you should be having. Well, in 2007, we realized that IVs are hard in dead people. And we were spending so much time putting IVs in. Again, you're losing focus on other things. So the IO was developed, and it was a good idea. It was quick. We moved on. Obviously, the flow through the IO is slower than an IV, but the thought was all the time spent on the IV is made up by a quicker IO placement, and yet flows slower, but at least they're getting the med in them faster. So they did this retrospective review a few different ways to see if the IO was better. They found that patients are getting epi faster with the IO. First attempt success was faster. And ultimately, they were still getting similar serum levels. So it was not worse. This was a good alternative. It was always tibial, and now we added humeral. Humeral is more difficult. It's more easily dislodged, lower first success, but overall, both routes have a similar infusion rate of about a 21 gauge IV. So why wasn't it the standard? Well, there have been multiple studies that have come out that show it's comparable ROSC. They found no big difference. But ultimately, this 2021 study was kind of the nail in the coffin, where they showed that the IO patients had lower sustained ROSC and survival. So AHA recommends IV first. So interestingly, 2 trials came out simultaneously in the same edition of the New England Journal of Medicine, which is pretty unheard of, talking about the same thing. So again, in the UK, you had this open label trial where they gave patients epi through IV or IO, and they were looking at 30-day survival. They needed 15,000. They only got 6,000 before the study just kind of dissolved because of funding. So between the two, EMS arrived and got access in the same amount of time. So EMS arrived and got an IO or an IV placed at the same time, which as a longtime paramedic, that is not how that works practically. There's no way that an IO and an IV should take the same amount of time. They found first attempt success with an IO was more, and they found no difference in survival. So then you had the IVIO trial, which was out of Denmark, and they were looking at ROSC over 20 minutes. ROSC sustained for over 20 minutes. Their first attempt success was higher in IO. Again, we know that. Their time to access and first epidose was the same, which again, practically, I still struggle with that. And they found no difference in the time to sustained ROSC. Again, similar result, but there was something very interesting here. So what they did in the IVIO trial is, because they could do humeral or tibial, they did CTs of all the IO placements to see if the IOs were in place. And they found 71% of the humerals were in place, 100% of the tibials were in place. So there were 29% of the humeral patients that never actually got the right medicine, yet there was no outcome difference. So 29% didn't get the medicine, yet still had the same outcome. So really, rather than route, this really called into question, does the medicine matter? Is the medicine the difference maker if they're getting the same outcome? So ultimately, Paramedic 3 had better outcome to study. We were looking at survival. They got the same result. IO was successful more often, but not any quicker, which again is just not real life. It would be nice to see if just doing no meds, no access would change anything. And then it just again calls into question if medicines matter. And we'll end with the Opals trial, which also calls that into question. So antiarrhythmics, so your amiodarone, your lidocaine, that kind of thing. So these are basically here because of this study. There were 8 trials done. Lidocaine had more ROSC, amiodarone, lidocaine had more survival to admission. That said, no antiarrhythmic was more effective than placebo for survival, and no antiarrhythmic was convincingly superior. But back in the day, they cared about ROSC, so amiodarone and lidocaine entered. Ultimately, though, neither one of them's better. There was a bigger one done, 39,000 patients. This was a massive global study, not just in the United States. They were looking at medicines we don't even have in the United States. They were doing all different arms of this study, antiarrhythmic versus a control, antiarrhythmic versus a placebo, and then different antiarrhythmics head to head with each other. They were looking at ROSC, survival, and neurologic survival. Amiodarone and lidocaine were obviously the most widely used. There was no significant effect on any outcome. And then the only drugs that suggested benefit are not available in the US. They're European drugs. But none of them had any effect on survival to discharge. Some survived to admission, but none to discharge anymore with a specific antiarrhythmic. The ARREST and ALIVE trials showed that amiodarone increases ROSC, so ACLS includes it. But ultimately, we need more research. This is another thing. Not the difference maker, but really not causing harm. Quick note about bicarb. This is something that often we used when I was a medic. They've been down a while. I bet they're acidotic. Let's give them bicarb because that'll help. That's ultimately been disproven and actually been shown to trend towards harm at the ICU level because it screws up their acid-base physiology as they're trying to heal if they're dumped full of bicarb. So we are not using it in just these prolonged downtime patients. There are times for bicarb, specifically if you've been ventilating well the whole time, if you're worried about certain types of overdoses in conjunction with poison center or toxicology, and then hyperkalemia from like missed dialysis, that kind of thing. If you have a hyperkalemia concern, bicarb is great. So I'm going to fly through this because I want to get to the last part. Ultimately, this is not new anymore. This was groundbreaking a long time ago. But ACLS for the longest time was compressions, defibrillation, airway. We talked a little bit about team dynamics mattering. Well, this is why. So Salt Lake City Fire completely changed how they do things. They were given discrete tasks before they got there. So again, I come on scene based on where I am in the engine. I know what my role will be. Every patient is going to a STEMI center where they can get targeted temperature management and a stent, and then they get repeated training. So they were going to get real-time feedback, post-incident feedback. They were doing selective pulse checks, which was kind of unique. So there were specific reasons that they would check a pulse, otherwise just continuous compressions and airway. They stayed on scene. They had to have specific good prognostic signs to transport or continue. And then again, these things I mentioned earlier, those are kind of universal rapid transport things because there are hospital measures we can take that improve. And then online med control was involved. So they could do passive ventilation if it was a witnessed arrest, because again, they're freshly dead, so defibrillation matters. So they would just put a non-rebreather on them for 6 to 8 minutes while they did other things. If it was unwitnessed, they would do the typical BVM asynchronous ventilations. So their typical system, before they did anything, 36% were resuscitated, about 8% meaningfully survived. Pretty standard to national data. Like they're a very typical system. After their changes, they still resuscitated about 39%. 16% survived. They doubled their survival with good neurologic outcome. The number needed to treat to gain another survivor was 12. The smaller that number is, the more amazingly meaningful that intervention is. So aspirin, which improves mortality in ACS, has a number needed to treat of, I think, 62 or 64, and even that's amazing. So they need to do it this way for 12 people to save a life. They ultimately shut this study down because they said it would be unethical to change anything, to not change the other group. And then increase in function, 8%. So the other things that they found was bystander CPR went up, ROSC in the field went up, there were less fetal transports, increase to survival to discharge improved. But ultimately, the biggest thing was their discharge with good neurologic outcome went to almost 50%. Their CPR quality got better, their rate slowed down, their depth got bigger. They had more compressions within the desired compression fraction and guidelines. So they had minimally interrupted CPR, on-scene resuscitation, pre-assigned roles, all these things we've been talking about. They also have found other systems are doing these same things now. This pit crew model is everywhere. And it's hard to know exactly what the difference maker is, but we know that the BLS interventions are what save lives. That's why we spend so much time on it. Compressions, defibrillation. So this is kind of the final big question. Do the ALS skills change outcomes? So the OPAL study is the main study that has had offshoots from it. It's the main data set. But this looked at ALS interventions and out-of-hospital cardiac arrest. It was multi-centered, controlled clinical trials in 17 cities, so very widespread. Looked at outcomes before and after ALS interventions were introduced. So those interventions were intubation, manual rhythm analysis and defibrillation, and IV meds with epi, amiodarone, all that. They looked at 5,600 patients, about 1,300, 1,400 pre, so just typical BLS care, compressions, AED, transport, and then 4,200 patients got full ALS care. It did not change survival to discharge, good neurologic outcome. There was no improvement in the rate of survival with the use of ALS. They were mainly talking about intubation, IV placement, medications. It did not help neurologic survival. So there are, though, areas where it might help, right? So overdoses, certain metabolic disturbances, drownings. You know, drowning is a hypoxic event, so we want to intubate those people because we need to reverse. That's the reversible cause, is the hypoxia. But those things aside, in just your run-of-the-mill medical adult arrest, the ALS interventions are not the difference maker. Compressions, defibrillation. So the odds ratio of survival, so the intervention to survival, the ALS interventions was 1.1. So basically equal to chance that adding that changed anything. Bystander witnessed arrest was 4 times more likely to be associated with survival. Bystander CPR, rapid defibrillation, these are all almost 4 times more likely to improve survival. So this is something that I talk about in my county too, because I medically direct all the first responder services. This comes right out of this OPAL study. In order to save lives, healthcare planners should make CPR by citizens and rapid defibrillation responses a priority for systems. So it is important to empower both your citizens and your first responders that they are the difference maker, because this is what matters. They speed up or shorten, I should say, the no-flow time, and they are doing the main interventions that even when all of us advanced providers get there, we're doing the same things. This is its own thing. It's super exciting. So I'm on the executive committee of our eCPR program at the university too. There are specific types of cardiac arrest that would benefit from extracorporeal life support. That's a really exciting field, logistically very difficult, but there's some cool stuff on that too. So just know that it's out there. But ultimately, what matters most, you've heard me say it now about 15 times, high quality CPR, early defibrillation. You want to optimize your team dynamics. Pressors and antiarrhythmics do not improve the neurologic outcome. And the IOs are faster. You get higher first attempt rate and comparable kinetics. So even though ACLS says it's not the priority, it's by no means not a bad option. And especially if you're in the field, it is a quicker option to get things rolling so you can focus on the other things. Because even if you're worrying about access and using the IVs like they say, as we've seen, the medication is not the difference maker anyway. So any questions? Yeah.
Just a quick word about hypothermia. Is it helpful after arrest? Hypothermia to try to improve the potential of neurologic success?
Yeah, I mean, they still waffle on the exact type of hypothermia. They give you that range, but it has expanded now to, it used to just be shockable rhythms. Now it's everybody. Anyone that survives, they suggest it. but they say the newest update was less about hypothermia and just making sure you get to around, euthermia. Because practically it can be difficult to get the hypothermia, and starting it in the field definitively does not change anything. They've shown that too, because there's no way to bridge that gap and know that it's consistent. So it's still talked through, but it's not as emphasized as it used to be.
Then I know that capnography is measuring CO2, but what exactly is the device?
So it's there's a few different ones. There's an inline one that can just be like a nasal cannula. Obviously, in these cases, it's more often connected to the actual circuit, whether it's through a BVM or the endotracheal tube or the supraglottic airway. And so the air that's going by, if it's connected to a ventilator or whatever, is then giving you the readings of the expired CO2. So it's just it's a small connector piece is what it looks like, but with a wire then connected into your hub on your monitor. Yeah.
So the idea of head up when you're doing resuscitation, what does that mean? I mean,
Yeah.
Is that just the head on a pillow, or?
I know I should have put a picture. There's just it. So the main device. So the short answer is it's basically a pillow that connects to the Lucas device. So not coincidentally, in my mind, the big proponents of this are the same people that manufacture the Lucas device, and coincidentally, it fits together perfectly with the Lucas device. But it's essentially this inclined pillow about this big. And so, you have them in the Lucas device. They're strapped into it. You add this it almost looks like a wedge, and it takes them up to from about their upper thoracic spine. It just tilts them up a little bit. So they're still attached to the Lucas. They're just kind of not flexed enough that you're kinking anything, but it's not a full body sitting up. It's
This is not something that you're pursuing at this time.
No, though, interestingly, at our national conference, the year it came out, on their poster, it said being pursued by the Johnson County Ambulance Service. And so I went over and said, well, hey, I'm the medical director. I've never heard of you. He got real wide-eyed. And I guess one of my medics had called them to ask about it, and we ended up on their poster.
There you go.
But no, we're not right now. Yeah. Thrown in the back here, yeah.
One hot topic in our organization right now is partial code and picking and choosing of whether shock and meds and, really your flavor of interventions based on patient wishes. Could you give us your stance on that?
Like somebody that doesn't want to be intubated but wants to be.
Maybe they just want meds. Or they no shock code type thing. Doesn't happen often, but there have been patients that state, they only want certain interventions in those situations.
Huh. I guess, yeah, I've never gotten it down that delineated. I just help them understand. Like when I get someone that says, I want to be intubated, like if my heart stops, I want to be intubated, but I don't want CPR, I explain, I'm not going to do that. It's not going to do anything. But I just try and explain to them what we're doing and why. I just give them the information. If they want to do it that way, knowing with the information, I guess we'll do that. But I haven't been in that scenario. But in general, I just try and clarify what these things do and don't mean. One thing I'll do a lot with termination too is, often we'll bring family back and we'll say something to the effect of, you've seen them, we'd like to stop. Is that okay? Almost making it seems like a lot of families walk away thinking, I just killed my loved one. I just had to decide this. So personally, I often say, if we've gotten there, we're at this point. After the next pulse check, if we do not see this, I am going to stop. Because I would rather be the villain that they live with forever than them thinking, oh, what if I had let them do this one more time? So you want to empower them with the information, but also unbear their burden, So in that scenario, if it clinically didn't make sense, I probably would just explain that's not the order that we could do. Unfortunately, you probably could do no shock CPR forever. You would just compress them to oblivion, but then you would just decide as a team to stop. But yeah, I'd probably just give them information. but that's tough. That's, yeah.
Thank you.
Mary Greeley was the first hospital in Iowa to have a paramedic training program. How many training programs are there in Iowa? And could you just briefly tell us? I know there's a lot more training for paramedics than EMTs, but could you just give us a quick overview?
Yeah, I don't have an answer on how many programs. Unfortunately, since COVID, they've drastically dropped. It's probably less than 10 for a variety of reasons. I mean, the field in general, just enrollment has gone way down. The difference in training is just really, it's twofold. It's the depth with which they go in. So paramedics will have much more physiology, anatomy, pharmacology. And then procedurally, they have a much vaster scope, you know, IVs, IOs, different airway managements, different medications, ventilators, that kind of thing. And then the actual, from an education standpoint, the difference would be their clinical ride time. So the time in the hospitals, the time in the field, they have a much longer kind of field externship. EMTs will do a couple shadow shifts clinically and then in an ambulance, but they're very much entry level to identify sick or not sick, to stabilize big life threats, you know, CPR, airway, give oxygen, give them an aspirin, that kind of thing. But in terms of interventions and more critical thinking skills with a bigger arsenal of pharmacy and technologic skill, would be the paramedic. So, but yeah, the landscape's changing a lot. And Iowa is a very, now putting my state hat on, Iowa is a very difficult state because we're 70% rural and over 80% volunteer of our EMS service. And so volunteer people are, I mean, that whole generation is retiring, as they should, and there's just really not people filling the gap. So we have a lot of difficulties in that respect as well. And I know there's a lot of towns that struggle with that. Any other questions? I appreciate your time. Thanks for having me.